Good evening. Thank you for joining us for tonight's Lung Life webinar, Sleep Apnea 101 with lung and sleep medicine specialist, Dr. Colin Ellis. My name is Jill Hubick. I'm a registered nurse and certified respiratory educator with Lung Saskatchewan. It is my pleasure to welcome you and to be your host and moderator. Before we begin the presentation tonight, I would like to acknowledge that the land we are hosting this webinar on is on Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, and Nakota Sioux, as well as the territory of the Métis. Lung Saskatchewan affirms our commitment to reconciliation and the Truth and Reconciliation Commission of Canada's calls to action. We acknowledge the many First Nations, Métis, and Inuit whose footsteps have marked these lands for generations, and we are so grateful we are able to host this event where we are. Supporting and helping people living with and caring for people with lung disease is a priority for Lung Saskatchewan. We offer a variety of online support groups for patients and caregivers. The support groups that we offer include asthma, COPD, pulmonary fibrosis, COVID-19, lung cancer, lung transplant, sleep apnea, and Saskatchewan Quits to help people quit smoking. These support groups are here to help those living with lung disease or for those who want to quit smoking navigate their journey in a supportive way. Providing education and support is one way we hope to help you live your best lung life. If you are not a member of our Lung Saskatchewan support groups and would like to be, we would love to have you. Visit our website at lungsask.ca. So perhaps you are tired and you don't know why. Maybe you have been told you snore loudly and sometimes pause with your breathing when you sleep. Or maybe you have several risk factors and you want to know how you can be tested for sleep apnea. We're excited to learn all about sleep apnea tonight from Dr. Ellis. Following Dr. Ellis's presentation, we will have time for a moderated question and answer period. So if you have questions for Dr. Ellis, please type your questions into the question feature of the webinar software. You will find this feature in the control panel on the right-hand side of your screen. All right, it is now my pleasure to introduce our presenter. Dr. Colin Ellis is a respirologist and sleep medicine specialist based here in Saskatoon, where we are hosting this webinar. He is also an assistant professor in the Division of Respirology, Critical Care and Sleep Medicine at the University of Saskatchewan. Dr. Ellis completed his internal medicine residency and his respirology fellowship at the University of Saskatchewan. He then completed a fellowship in sleep disorders medicine at the University of British Columbia. Dr. Ellis has clinical interest in sleep disordered breathing, the respiratory management of neuromuscular disorders, and he is passionate about helping patients and their caregivers live better with sleep apnea. Sleep is a vital part of our health, and we know that sleep apnea is serious, but that it can be treated. So first, it starts with education. And tonight's presentation is the first of our 5-part 2023 Lung Life webinar series sponsored by GSK. Lung Saskatchewan and GSK have a long history of working together on activities that improve the lives of those living with lung disease. This educational webinar series, Lung Life, was created to empower those living with and caring for those with lung disease to live better. This is the 3rd year of our Lung Life series partnership, and together Lung Saskatchewan and GSK will be bringing you presentations on different lung health topics throughout the year. If you miss any of these webinars, we hope you'll visit our website, lungsas.ca, where you can view their recordings. Here is a short video about the series. The Lung Life webinar series would not be possible without GSK, a science-led global healthcare company with a special purpose: to unite science, technology, and talent to get ahead of disease together. The Lung Life webinar series is rooted in science, utilizes technologies to make education from a talented expert accessible to you, wherever you are. I am very pleased to welcome Marie-Claude from GSK to bring greetings tonight.
Bonsoir everyone, my name is Marie-Claude Desaulniers and I am the Patient Engagement Manager at GSK in the Patient Affairs and Advocacy team. In the scope of our work, we engage with patient organizations by listening to patients throughout the life cycle of our medicine, integrating those insights into our business planning to improve patient outcomes. GSK is very proud to collaborate with LungSask and to support the 2023 Lung Life webinar series. LungSask is providing you with accessible, practical, evidence-based information and strategies coming from key leaders in their field of expertise. The topics of these webinars have also been chosen based on your feedback, which is so important to listen to in order to bring the relevant informations which we hope will help you live a better long life. Thank you very much and have a great evening.
Okay, well, hello everyone. Thanks for attending this talk. My name is Colin Ellis. I'm a respirologist and a sleep medicine specialist. I work in Saskatoon, and I'd like to thank the Lung Association for asking me to give this talk. Yeah, it's called Sleep Apnea 101. We'll just get started. So I'm mostly going to be focusing on obstructive sleep apnea. It's the most common type of sleep apnea. And we're just going to be focusing on two main parts of obstructive sleep apnea. So we'll talk all about how it presents, what the pathophysiology behind it is, what sort of consequences are associated with sleep apnea. And then we'll talk a little bit about the treatment of obstructive sleep apnea. So obstructive sleep apnea at its core is repeated collapse of your upper airway while you're sleeping. So how I usually tell people is that it is just repeated choking episodes while you're sleeping. And this leads to impaired sleep with, you get low oxygen levels, you get sleep fragmentation, and you get circulating, hormones like adrenaline while you're trying to sleep. And that leads to a number of issues with daytime function, and that includes, your thinking. It can lead to symptoms of depression, anxiety, and it can also have an effect on a number of organs, including your heart and your kidneys, and it can lead to stroke. So if you're looking at this picture here, so why does someone have repeated collapse or choking episodes while they're sleeping overnight, whereas someone else doesn't? So if you look here, you can see that the obstructive sleep apnea is mainly a disease of the area right behind your, like the palate, the top of your mouth, right behind there down to right above your vocal cords. And that's this part right about here. This is your epiglottis right here. So it's a disease of this part of your body right here. And you can see that in this individual, this big black tube here is open when they're awake, and when they're sleeping, boom, it's closed like this. And there's two main, just have to move this out of the way here. There's two main ways that, or there's two kind of contributors if you're to lump everything together. You know, it's a pretty complicated process, but essentially you have the structural obstruction of it, and that can include things that are modifiable. So if we gain weight, oftentimes we'll get deposition of, we call it adipose tissue or fat tissue in your neck, in this throat area, that causes increased pressure on your airway while you're sleeping. That can increase it or cause it to collapse. Or kind of non-modifiable things like, you know, you inherit your craniofacial anatomy from your parents. So that means you can inherit obstructive sleep apnea from your parents as well. You also inherit where you deposit, you know, this fat tissue. So some people will have a tendency to deposit it in their neck and in their upper body, whereas others will deposit kind of in the lower body, kind of leaving their neck free. So it's different for every person. Other things that can cause some structural obstruction there would be enlarged tonsils, and then fluid redistribution. So, you know, I think most people have experience where if they're standing and working during the day, they'll get increased swelling in their ankles. Taking it a bit further, some people who do have some problems with their heart might get even more swelling in their ankles. And then when you go to sleep, it's often commented that, yeah, I have swelling in my feet, but then when I lay down and sleep, it goes away overnight. And the reason it goes away is that when you lay flat on your back, that fluid that is in your feet redistributes throughout your body. And if it is a lot of fluid and it redistributes, you know, throughout your body and up into your neck, then that can cause some obstruction in your airway as well. But the structural problems is not the only thing that contributes to these choking episodes overnight. The area in your throat here is not really supported by any bony structures. There is, you know, one bone there, but it's a very complex structure in your body that, you know, does a number of things, including, you know, breathing, swallowing, speaking. So there's a number of muscles there. And when you fall asleep, you know, every muscle in your body relaxes, and that includes, you know, the muscles that keep that airway nice and open, like a nice big circle. And that includes the muscle that protrudes your tongue. And some individuals, for whatever reason, when they fall asleep, have less output from their nerves to those muscles to keep them nice and open, and therefore they're more prone to collapse. You also find that some of the reflexes that are present during the day are not present overnight. So if you were to take a very big breath in, you know, that creates a very negative pressure throughout your airway. During the day, if you're awake and your body senses that you're taking that negative pressure, it responds by increasing the motor output to your upper airway and gives more tone to those muscles, keeping them nice and open. That reflex is not present, or present to a lesser degree while you're sleeping overnight. So as someone is taking more of a big pressure in, or big breath in, that negative pressure tends to suck in the airway, reducing the tone even more. And then when you're in dream sleep, every muscle in your body is, you know, paralyzed except for your diaphragms, which are these big muscles here that do all your breathing. And that includes the muscles that are in your airway. So we often find that in dream sleep, obstructive sleep apnea is at its worst. So what happens then is that, you know, when a person is supposed to be sleeping, you know, nice, calm, quiet, relaxed sleep, restorative sleep, instead of that happening for, you know, overnight while you're sleeping, you're in this fight or flight mode. You know, your oxygen levels are dropping, you're getting a surge of adrenaline throughout your body, your blood pressure goes up, your blood vessels constrict, and it's been found that there's increasing circulating inflammatory markers in the body. So obstructive sleep apnea, although it's isolated just to this small but important part of your body, it can cause a whole bunch of effects that can persist throughout the day due to poor quality sleep, but also chronic health effects as well. So that leads to the consequences of obstructive sleep apnea. The things that people tend to notice is that, you feel sleepy during the day, fatigued, you have poor memory, poor concentration, or, any of these other things. So heart rhythms. So atrial fibrillation is a very common heart rhythm. And what happens is that, obstructive sleep apnea is associated with an worsening or increased prevalence of atrial fibrillation, and actually treating obstructive sleep apnea in people who have atrial fibrillation can help with the control of it, because it reduces the level of those circulating adrenaline. It's been associated with heart failure, with strokes, high blood pressure. It's even associated with increasing, erectile dysfunction, low libido, diabetes. So it can have wide-ranging effects on a person. So how is sleep apnea diagnosed? So anytime you're suspicious that you might have sleep apnea, the next thing to do is to do a sleep test. So, and then based on that sleep test, you can get a sense of how often someone is having one of these choking episodes overnight. And essentially, if someone is having a choking episode overnight and it's 10 seconds or longer, and their oxygen levels drop or they wake up, you score that as an event. So the bare minimum cutoff to diagnose someone with obstructive sleep apnea is if they have 5 of those episodes per hour. So if you're sleeping overnight, that's about 35 episodes of that per hour. And then, usually it says you can diagnose it with one of these associated conditions. So if you look here, like habitual snoring is one of those conditions. So if you snore and your AHI is 5, then you have been diagnosed with obstructive sleep apnea. But you can see here, these are the symptoms that you would expect someone to have with obstructive sleep apnea. Sleepiness is a big one. We'll talk about that a bit later. But non-restorative sleep, so someone will sleep, 8 or 9 hours a night, wake up feeling like they need to go back to bed. So they'll wake up, maybe get the kids on the bus to go to school, and then go back to sleep for a nap. Insomnia symptoms is a bit of a tricky one, because sometimes people don't associate that with obstructive sleep apnea. But if someone, at the beginning of the night falls asleep and then immediately starts having obstructive sleep apnea and then waking up repeatedly, then they'll have a difficult time falling asleep. If someone falls asleep and then later on in the night during dream sleep or something, they have worsening obstructive sleep apnea, then they'll wake up in the middle of the night, with all that adrenaline circulating throughout their body, feeling like, they can't get back to sleep. So it's associated with a number of sleep symptoms. What other people, come into clinic saying is that, I don't notice anything, but my bed partner says, I stop breathing overnight, or I'm choking overnight, or they count how many seconds I'm not breathing. They think I'm going to die. And then obstructive sleep apnea is associated with a number of other health problems, including high blood pressure, depression, anxiety, heart disease, stroke, congestive heart failure, diabetes. This is what obstructive sleep apnea looks like during a sleep study. There's a lot of information that we gather during a sleep study, but I'll just draw your attention here to these channels here. So this is your respiratory effort channels, these two right here. And you can see that someone is trying to breathe, nice and calm, but their breaths are getting bigger and bigger and bigger. And the reason is because here you can see that the airflow has essentially stopped. So they're breathing against a closed airway, they're choking. And you can see that the breath gets bigger and bigger and bigger. They're generating more effort, more effort, more effort. And finally, they have an awakening here. They can breathe normally for, a few breaths. So that's 1, 2, 3, 4 breaths. And then they fall back asleep, and that repeats itself. You can see here that this person's, oxygen levels are already a bit borderline. And then as they're having this choking episode, their oxygen levels just drops. And this oxygen level goes down to, this is probably in the 60s here. And then they wake up, they can breathe normally. All it takes is a few breaths to get that back up, but then it repeats itself. And it's the repeatability of this process throughout the night that drives the pathophysiology of the disease. So for some perspective, if someone has less than 5 of those choking episodes per hour, that's normal. If it's between 5 to 15, that's considered mild. If it's between 15 to 30, we call that moderate severity, and anything above 30 is considered severe. So to get a diagnosis of mild if you just had, you know, the bare minimum and that was 5 episodes, that would be about 35 events throughout the whole night. Say you're sleeping 7 hours. If it's moderate, you're now getting up to about 100 times per night where you're having one of these choking episodes. So 100 of these per night. And then if you're having severe, that's getting up to 200s. So about 210 if you're sleeping for 7 hours a night of having episodes like this where you're choking, you keep waking up, and your oxygen levels are dropping. So what are the symptoms of obstructive sleep apnea? So sleepiness is oftentimes, like, the poster child of obstructive sleep apnea is someone who can't stay awake during the day, or they keep falling asleep when they don't want to. But many people are surprised to find out that most people with obstructive sleep apnea don't report sleepiness. It is reported in about 40% of people, and those people do respond quite well to treatment for obstructive sleep apnea, but it's not the most common symptom. It's been found in some studies that depending on the reason the person or the associated condition that someone has with obstructive sleep apnea, that they're more inclined to be sleepy. So for example, someone who has obstructive sleep apnea and their other primary medical problem is asthma are more likely to experience sleepiness. Whereas someone else who has, say, atrial fibrillation or has heart failure is less likely to be sleepy with obstructive sleep apnea. Sleep apnea impairs your quality of life, and the impairment in the quality of life based on scores that are done across different studies is similar to what you'd experience if you had, you know, back issues or if you had arthritis. Someone with obstructive sleep apnea, or I guess obstructive sleep apnea in general, is associated with about a 2 to 3 times higher risk of having a car accident or having an injury at work. And then what's more concerning to people is that they're at higher risk of having a stroke, or they're at higher risk of having a heart attack. I wanted to draw attention to this because it's not very well known, but if you ask people about it, they tend to tell you about it. And basically, there's a condition associated with obstructive sleep apnea called pseudo-REM behavior disorder. And it's pseudo-REM because there is a disorder called REM behavior disorder. And basically, sleep is split up into, you can broadly classify it into 2 different categories. And there's REM, so rapid eye movement or dreaming sleep, and then there's non-REM sleep. And the dreaming sleep, or the REM sleep, is quite interesting because if you're looking at someone's brain waves while they're in dream sleep, it actually looks almost like they're awake. Like the brain waves look a lot like awake brain waves. But the difference is that someone will be completely paralyzed during REM sleep, and you can tell that because we can monitor their chin tone and their muscle tone in the sleep lab, and you can see that as they enter dream sleep, in addition to the rapid eye movements, they will also have a reduction in their chin tone. However, in REM behavior disorder, the ability to be paralyzed while you're dreaming is lost, and that results in people acting out their dreams. So they'll shout out, they'll yell at an attacker, they'll cry out for whatever reason overnight, or they'll do complex kind of movement overnight, like they're fighting, they're kicking, they're hitting, they might try to get up and out of bed. And that's behavior that is oftentimes noticed more and can be quite harmful. It can cause harm to yourself, it can cause harm to your bed partner. Oftentimes it is quite distressing to people, but the good news is that if you experience this sort of phenomenon, it's completely treatable if you treat the obstructive sleep apnea. So obstructive sleep apnea is actually a fairly new disorder. So it was really only characterized in the 70s, and the definition for hypopnea, which, an apnea is essentially where your throat is, or your airway is completely closed. We call that an apnea. Hypopnea, it was later identified that if you can have reductions in your flow, reductions in your breathing to about a level of 30% or more, and you can still have low oxygen levels and arousals overnight. So that was included in the definition by the end of the 70s. And CPAP, you know, it's well known now and it's in widespread use, but it was only invented in the 80s. So it's still a fairly new disorder. They used to think it was quite rare, but recently this study came out, I guess it's 4 years ago, where they used population studies to estimate the global burden of obstructive sleep apnea. And it appears that it's very likely that 1 billion people worldwide, or close to 1 billion people worldwide, likely have obstructive sleep apnea if you use the lowest cutoff of 5. If you use the moderate cutoff, it still is over 400 million people. So it's a huge number of people worldwide who are affected by this disorder. So if you've been diagnosed with obstructive sleep apnea, you aren't alone. That study only looked at people between the ages of 30 to 69, so the numbers are maybe a little bit of an underestimate as well. But if you look in Canada, you know, it's almost 5 million people in this age range who have a diagnosis if you use the cutoff of 5 events per hour. And then if you use the cutoff of 15 events per hour, it's a bit more than 900,000. So a huge number of people are affected. It's extremely common. It's probably underdiagnosed, not for lack of trying, but you know, I think a lot of people don't know about obstructive sleep apnea, and they can live years experiencing symptoms and the side effects of obstructive sleep apnea without, you know, finally getting some sort of investigations done. Oftentimes when I speak to people in clinic, they've had these problems for years and they've just been, you know, trying to get by and live with these problems. So if we can identify it, then we can potentially get people on treatment and get them feeling better sooner. So once you've identified the symptoms of obstructive sleep apnea, and like we talked about before, that's, you know, things like sleep disruption, snoring, unrefreshing sleep, someone else sees you stop breathing overnight or choking overnight, daytime sleepiness, that sort of thing. The next step is to get a diagnosis for obstructive sleep apnea. So a polysomnogram is a fun way to say sleep test. And there's 2 different sleep tests that are routinely available. So a level 1 study is the gold standard for diagnosis of obstructive sleep apnea. And those are only done in hospital in Saskatoon and Regina in this province. And the benefit of that is that you get kind of all the testing done at once. So if you see this person here, they have this mesh cap on because they have, just have to move this again here. So they have this mesh cap on because they have leads on their head so they can measure their brain waves. They have these things around their eyes so you can measure rapid eye movements, so you know when someone's in dream sleep. Something in their nose, this thing on their chin, so you can measure the chin tone. You have a band here and on your abdomen to detect respiratory muscle effort. And then you also have some stickies on your legs so you can measure leg kicks overnight. You know, oftentimes people wonder, you know, how could I ever sleep with all this stuff on? And I'm sure a lot of you had sleep studies and, you know, everyone has their own experience, but it is surprising. Most people do sleep in the sleep lab with this sort of thing on. It's good at diagnosing obstructive sleep apnea, but it's also good at diagnosing other types of sleep disorders, such as central sleep apnea, which we won't talk about today, hypoventilation disorders. So those are disorders where your carbon dioxide level goes up overnight. It's useful if you're curious about someone's sleepiness being related to something like narcolepsy, or if you're worried that someone is having one of those that REM behavior disorder, like they're acting out their dreams or something like that. So it's a good test for all sleep disorders and the gold standard for diagnosis of obstructive sleep apnea. For a lot of people with moderate to high probability of obstructive sleep apnea, you can get by with a home test. So a home test is also called a level 3 sleep study. So it's this person here has just these nasal prongs in, so that measures airflow. This is measuring their oxygen desaturation, and then this measures their respiratory effort here. It also can measure some snoring, and it can measure, you know, it usually can measure if someone's on their back or on their side and that. And it's pretty useful because if someone very clearly has obstructive sleep apnea based on history, then you can get the diagnosis done pretty quick with this test and get them started on treatment, a lot quicker. It cannot say that you don't have obstructive sleep apnea. So, another way of saying that is if your level 3 sleep study or home sleep test says does not confirm sleep apnea, then it's still possible that you have obstructive sleep apnea. And if you still have symptoms that you think are due to obstructive sleep apnea, then the next test would be a level 1 sleep test. Part of the reason is that this study, the home test, cannot measure the amount of sleep that you're getting. So you could put it on and then be in bed for 7 hours, and it'll take the number of events that you have, the choking episodes, and divide that by 7. But say that because you're wearing this thing in your nose and this thing on your belly, you didn't sleep for 2 hours. So it would never take out that 2 hours of sleep because it can only measure recording time. It also doesn't measure, because you don't have anything on your head to measure your brain waves, it doesn't measure the amount of times that you're waking up overnight. So some people can have obstructive sleep apnea where they're choking, but their body is able to terminate that event before their oxygen level drops to a significant degree. And you can still score that in the sleep lab, and that can contribute to their number for getting a diagnosis of obstructive sleep apnea. So yeah, there's a number of reasons that it cannot exclude obstructive sleep apnea, but it is still a useful test, and it's still appropriate for a lot of patients, probably most patients who you have at least a moderate to high suspicion of. Kind of newer is this level 2 technology. So it takes all of this that this person has on, and it moves it to your own home. So it's a home test, but you have all of these things on. So the benefit is that if you're looking for a diagnosis of obstructive sleep apnea, it would give you the sleep time. It's kind of the main benefit. But the downside is that the more complicated it gets when you're sleeping, the more at risk it is for having like the oxygen probe fall off or the nasal prongs fall out or something like that. And there's just no technician there to help monitor that and correct it. So, but that's a newer technology. So yeah, we talked about the home test. So usually, I did my training in Vancouver and for sleep, and they would not reimburse for a home test unless they met the criteria. So they have to have daytime sleepiness, and then check off 2 of these boxes here. There's another criteria where you have to measure someone's neck size, and if it has to meet a certain criteria to say that they're a high enough risk for having obstructive sleep apnea. But in general, this would be someone who's at moderate to high risk for having obstructive sleep apnea. And we kind of talked about that, yeah. And then like the hypoventilation disorder. So if you're worried that your carbon dioxide levels are going up overnight, the home test, there's no home test that routinely measures that. And that can actually be a bit of a finicky test to do, or a finicky lead to apply. If someone's on long-acting pain medications like slow-release dilaudid or morphine, or if they're on methadone, they're oftentimes at high risk for having essential sleep apnea. And then if someone has a significant degree of congestive heart failure or COPD, then oftentimes it's better just to get them into the sleep lab as well, because they'll have more reasons to have low oxygen levels overnight that aren't just sleep apnea related. So kind of the more complex someone's medical history is, it's oftentimes better just to get them into the sleep lab. All right, and we talked about that. So we'll talk about treatment now. So these are the kind of treatment modalities that we'll discuss today. The mainstay of treatment is PAP treatment, so positive airway pressure. The one that's best well known as CPAP. We'll focus most of our attention on that. I don't think I have any slides talking about BiPAP or ASV, but perhaps if that comes up in the question and answer period, I can answer those questions. The second line therapy is an oral appliance. We'll talk about that as well. And surgery has fallen a bit out of favor, but a lot of people have questions about it, so we'll talk about that as well. And then talk a bit about positional therapy as an alternative. So what are the goals of therapy? So why do you want to treat obstructive sleep apnea? Far and away, the best evidence, in 2023 is to improve symptoms. So the number one reason to use CPAP to treat obstructive sleep apnea is to improve your quality of life and the quality of your sleep. We like to think that we're doing that by normalizing the the apnea-hypopnea index. So if someone was diagnosed with severe obstructive sleep apnea with 60 events per hour, then we can, essentially get that to 0. Usually we target for less than 5. But we like to see, we'll follow up with CPAP downloads and that, try to get that number as low as we can so that the person can feel as normal as they can. And then we want to make sure that someone who is getting treated for their sleep apnea has normal oxygen and carbon dioxide levels. And if they don't, then they might need more investigations or perhaps some other type of modality or supplemental oxygen. The first step, in treating anyone for any sort of medical disorder is education about that disorder. So treatment for obstructive sleep apnea is unique. It oftentimes gets a bad rap, especially CPAP gets a bad rap, because you'll see a study come out comparing it to treatment for things like high cholesterol or high blood pressure or diabetes. And CPAP oftentimes goes to the lowest when it comes to adhering to treatment to CPAP. And I think most people here have a lot of common sense, and they can tell that there's a huge difference between taking a blood pressure pill once a day in the morning with a cup of water and fundamentally changing the way you sleep by wearing a CPAP device for 7 to 8 hours overnight. There's also a major difference in the ability to monitor adherence to therapy. So your blood pressure pill bottle doesn't have anything on it that tells your doctor that you are taking all your blood pressure medications as prescribed and when needed. Whereas when you go in to see your doctor about obstructive sleep apnea, you're going to have a download, or the doctor will log in to their AirView account, and they can see detailed data about every night that you've worn this device. So kind of derailed myself, but going back to education. So because CPAP requires much more of a buy-in than just taking a pill, it's important for the person who's going to be using this to know what is obstructive sleep apnea and why should they care about treating it, especially if their symptoms are on the lower end of normal. It helps to know how severe it is, and especially relative to other types of sleep apnea, or sometimes you'll give them the number of again, your number is 60. Well, what does that mean? So it's good to have education, know what the condition is that you're treating, or else it's going to be difficult for you to want to use your CPAP device overnight. And then a lot of people are worried about the consequences of sleeping like this, knowing that they stop breathing 30 times per hour and have low oxygen levels. They worry about their future risk of stroke or future risk of heart attack. So it's good just to have, it's never good just to get a treatment from a doctor who says just use this. It's oftentimes good to know exactly what it is that is being treated and why it's being treated and what the benefit is to you. So education, in addition to just education about obstructive sleep apnea, includes education about things that you can do before you even formally treat it that would help improve the severity. So because obesity is such a huge risk factor for obstructive sleep apnea, pretty much every person who is overweight, or even people who are normal weight, are counseled on the effects that weight gain or weight loss might have on the presence or severity of obstructive sleep apnea. And oftentimes it's easiest to quote people, that a 10% change in your weight either way can have a pretty significant effect on the presence or severity. So, as you gain weight, you have a much higher risk of having moderate to severe obstructive sleep apnea. As you lose weight, there's oftentimes overall, there's a significant reduction in that number, and that number is and this changes in the weight or the change in the severity of the sleep apnea depend on the person. So it's not that all comers, if they lose 10% in their weight, will only see a 26% decrease in their apnea-hypopnea index. Someone might have complete resolution of their obstructive sleep apnea with 10% decrease in weight, whereas someone else might not have any change at all. And that's because there's more than just weight that contributes to obstructive sleep apnea, although it is a major risk factor. Other things that we say is that, I think a lot of people have noticed that their snoring or their sleep apnea seems to be worse if they've had, a couple glasses of wine pretty close to bed, or if they've had some friends over for the weekend. So alcohol definitely loosens the airway and allows it to collapse even more and worsens obstructive sleep apnea. There's some medications out there that also worsen obstructive sleep apnea, and those are medications like, again, pain medications like morphine or Dilaudid can relax your upper airway. Things like benzodiazepines, Ativan's a common one, or lorazepam would be the other word or other name for that. Temazepam is another one that's often used for sleep. Clonazepam, those medications also relax the upper airway. Gabapentin is another one. So those sorts of medications tend to worsen obstructive sleep apnea. Just the point about weight loss and the airway. So this is a patient who had this imaging done of their airway before and after losing about 18% of their body weight. Or no, it's about 10% of their body weight, 18 kilograms. So you can see here, so there's your airway is actually there's quite a few places where there is obstruction in the airway. So this would be the area kind of right behind your tongue. This is the area right below your tongue, right above your vocal cords. And then this is the area that's kind of behind your palate, so the top part of the roof of your mouth, and then upwards towards where the airflow comes in from your nose. And so there's different areas of obstruction here on this patient, or of structural obstruction on this patient's awake imaging. Now they lost weight and they had opening of their airway at multiple different areas. Okay, and then this person, so before they lost weight, they had severe obstructive sleep apnea. They had choking episodes 55 times per hour, and then after losing this amount of body weight, that number came down to 15 times per hour. So although it didn't completely normalize, it improved substantially. So, and this is only about 24 weeks. So it definitely is worth it for everyone, just for, as good health advice, but also as it relates to obstructive sleep apnea, is to make attempts to lose weight. Again, kind of going back, so, we advise people to lose weight. The effect is unpredictable in people. So some people might have complete resolution of their obstructive sleep apnea regardless of the severity, but some people might have only a mild benefit. Some people might not have any benefit at all. And that's because, again, weight only explains about 60% of the variation in the apnea-hypopnea index, and the rest is related to, again, the neuromuscular tone in the airway and your craniofacial anatomy. So after we've gone through education, we talk about the first line therapy, which is CPAP. So CPAP was invented in Australia by this doctor, Dr. Sullivan. And basically, before CPAP was available as a treatment option for people who had severe obstructive sleep apnea, the only treatment that was truly possible was doing a tracheostomy. So that's where they make a surgical incision in your throat here and then put a tube into there so that you breathe through this tube here, and that bypasses all of the obstruction that would be here. And that was the only treatment. And this doctor had a patient who didn't want to go through with that. So they developed CPAP, which essentially they just took a vacuum cleaner and reversed the flow. And then they used to have to they took a mask and they had to glue it onto the patient's face every night to keep it on there. And it was just a nasal mask. And they found that it significantly improved their symptoms and their apnea-hypopnea index. So how it works nowadays, we're lucky we don't have to glue masks onto our face anymore. But it's the first line therapy. It's the most effective therapy for obstructive sleep apnea. It can, regardless of the severity of obstructive sleep apnea, there's very few patients who cannot get their number back down to normal. So we see people in the sleep lab all the time and their number is above 100. And then we can see later on when we put them on CPAP that number goes down to 0. So you can, even though you have obstructive sleep apnea, you can start on CPAP and the very next night sleep as though you don't have obstructive sleep apnea. It's the best at normalizing that apnea-hypopnea index. It has benefits in terms of reducing sleepiness. It improves your sleep quality. It can improve the function of the, or not the function of the heart, but it can improve high blood pressure. there's a number of benefits to CPAP. These are all things with good quality data that CPAP improves. So, sleepiness, quality of life, like those are important things for people. Oxygen and carbon dioxide levels, control of atrial fibrillation, erectile dysfunction, and blood pressure. They've actually found that people who are be able to use CPAP participate more in physical activity. What you won't notice on this page is improvements in heart attacks, heart failure, stroke, or death. And the reason for that is that there have been some clinical trials that have tried to answer the question as if you treat someone with obstructive sleep apnea with CPAP, does it prevent heart attacks and strokes? And in the trials that have been done, the answer so far has been no, it doesn't do that. And the main reason for that is that in those clinical trials, it's considered to be unethical to enroll anyone who has symptoms of sleep apnea. So if anyone is sleepy or has fragmented sleep or complains of fragmented sleep, has unrefreshing sleep, those people just get CPAP and they don't get enrolled in the trial. The only people that get enrolled in those trials are those who don't really have much in the way of symptoms. And as you can expect, the buy-in for therapy during those trials has been quite low. So they only wear CPAP about 3 hours per night. So you can imagine that if you only took half or a third of your blood pressure medications, you wouldn't be surprised to find out that your blood pressure is not treated. So in those trials, if they took only the patients who actually wore CPAP for over 4 hours, they found that there appeared to be a benefit in, prevention of heart attacks and strokes. But just because of the way those trials are designed, you can't say definitively that it does that, but most people or most sleep physicians would agree that there likely is a benefit in prevention of heart attack and stroke. So CPAP is dose dependent. So if you're sleeping for 7 hours a night, the right amount of time to wear CPAP is probably 7 hours a night. There is this adherence criteria that has kind of been perpetuated throughout the literature. It's hard to know where exactly these numbers come from, but it's thought that, I guess it's not optimal adherence, but satisfactory adherence would be wearing it for 4 hours a night for 70% of the nights of the week is considered optimal or satisfactory. I think this comes from reimbursement for CPAP from United States. So if someone doesn't meet this criteria, then they don't get reimbursed for their CPAP. But there's not good quality data behind this. What's been found is that depending on what you're trying to treat, you should wear CPAP for a bit longer. So in clinical trials, it's been shown that sleepiness, objective measures of sleepiness improve if you wear your CPAP for at least 4 to 5 hours a night. Quality of life, it's a bit of a range between 4 to 7 hours per night. If you want to improve your memory, your concentration, then you have to wear CPAP a bit longer, about 6 hours per night. Depressive symptoms in trials of people who are kind of asymptomatic from a sleep apnea perspective actually improves if you wear it for around 3 hours per night. And then high blood pressure takes a bit longer, 4 to 5.5 hours per night. So just sticking to that 4, and this is wearing it all nights of the week, not 70% of the nights of the week. So just sticking to that 4 hours per night, 70% of the nights is it's not really the best way to go about it. If you want to wear CPAP and you want to get more benefit from CPAP, you just have to wear CPAP for longer. And in trials, again, with minimal to in what you would call asymptomatic patients, so people who didn't have symptoms of sleep apnea, so sleepiness, fatigue, unrefreshing sleep, and then were enrolled in these trials, even though they didn't wear CPAP for that long, they still found when they did their scores later, comparing it to people who didn't use CPAP, they found that there was an improvement in their scores for sleepiness that were improved to a significant degree, improvement in their anxiety and depression scales, improvement in their quality of life questionnaires, and they found that they were less absent from work. So what I often try to tell people is that, or what we discuss in clinic when we're talking about if someone should trial CPAP or not, is that I think people are pretty resilient, and they deal with things for a long period of time before, or some people might deal with things for a long period of time before asking for help. And people tend to adapt to feeling a certain way. And it's, a few times a week I hear someone who goes on a CPAP trial and they don't actually feel that much better when they're on the trial. They're like, oh, maybe I feel a bit better, maybe not. But then they have to give the CPAP machine back. And when they give it back, that's when they notice, oh, things got way worse. Oh, so, I think people adapt to feeling a certain way, and you'll never know if you've done that unless you don't try CPAP. So CPAP, of course, CPAP is just a box that blows air, but in order to treat someone, it has to be connected to their face with a mask. And, luckily we don't have to glue masks to people's faces anymore to treat sleep apnea. And because CPAP can be so difficult to tolerate, there's a huge number of options out there, including masks that go over your full nose, over your nose and your mouth, masks that just stick into your nose like a pillow mask. So there's a whole number of options out there. I think in general, the best mask for you is the one that you can wear. So you have to find it comfortable because it's going to be really you that is going to be wearing this overnight. In general, if people are asking me what they should do, the nasal mask is the first line option. And the reason for that is that when you blow air, when you use a nasal mask, number one, when the air goes in, it kind of goes through the back of the throat, and then it doesn't have to bypass the tongue or anything. So what's been found in trials is that if someone wears a mask that covers their nose and their mouth, then they often need a higher pressure to treat the sleep apnea. And that's thought to be due to the mask, like with the straps and that, pushing back on the jaw. So it prevents your jaw from coming forward and it pushes back the tongue. And then there's also a larger surface area that you have to cover. So if you're someone that has struggled with leaks, then you put this mask on your face that covers all the way around here. You have to control all that surface area for leaking. Whereas if you just get a mask that covers your nose, that's a much smaller area that you have to worry about, especially if you're someone who has a mustache or you have a beard and you don't want to shave it all off. The nasal mask is the way to go. Again, recognizing that there's certain reasons people want to use a different mask, so the best mask is the mask that works for you. There's people who don't have teeth or don't wear their teeth or have dentures, and oftentimes it's difficult to get that face structure that supports a full face mask, so they might leak out their cheeks here. You hear that kind of like farting noise overnight when it's blowing air out of there. Yeah, so you might have to try, so if you're having trouble with masks, then oftentimes it helps to trial several different masks, recognizing that is a bit of a limitation when it comes to cost and that. And what a CPAP company will provide for you. Sometimes people can't use a nasal mask, and when you talk to them, it's just that they have like plugged nose. And you can treat nasal congestion. You can treat it with nasal sprays, and in most people it's quite effective. And then they can wear a nasal mask, and that's done. Some people find that they can't use a nasal mask because when they wake up in the morning, they have a severely dry mouth. And if you wake up in the morning, if you have a nasal mask and you wake up in the morning with a really dry mouth, that probably means that air is leaking out of your mouth, regardless of what it says on your CPAP machine about leak. So the first step that I tell people is that you should get a chin strap. So it's a strap that goes under your chin and over the top of your head with the goal of keeping your mouth shut. And you can get different tensions of those chin straps to help keep it tighter. Some people, though, don't really like that, so they just end up going to a full face mask. The biggest thing is that, CPAP is very beneficial, but there's people who don't like things on their face. They're not used to wearing things like that on their face, or they're claustrophobic. And we've had success with a number of people who have been able to desensitize themselves to the mask during the day. So you can imagine that if you have slept for 50 years without using this, and now a doctor is telling you that you should wear this machine overnight to treat your sleep apnea, and you're someone who doesn't like things on their face, then if you are tired already and you go to bed at the end of the night and you are exhausted and you want to go to sleep, and then you see that CPAP machine and mask there and you put it on, it's a bit uncomfortable, you might just be inclined to take it off. And so what I tell people is that if you're struggling with getting used to your CPAP machine, then the absolute worst time to try to get used to it is at night when you're trying to sleep. So it seems a bit counterintuitive, but what has been helpful for a lot of people is to just wear the mask during the day when you're not trying to sleep. So if you're, sitting around watching TV or you're reading a book, just put your mask on and then try to get used to it then. Try to get, like, you're awake and you have the bandwidth to get used to it. So you can kind of fiddle with the straps. You can get used to what happens if, say, you turn your head and it kind of pops out, you can put it back in. If someone's able to get used to it that way, I say then while you're awake, just plug in your CPAP machine and turn it on and get used to the air coming at you. And it's way better to do that sort of stuff during the day while you're awake and have that bandwidth than to do it at night in bed when you're trying to fall asleep. The best way to fit a mask is if you have the pressure on and you're in a sleeping position, because then you kind of know how it feels and how it's going to push up on your face and that. Some people find that they just get the wrong size of mask. So if you over tighten your mask, then you're going to tighten up certain spots and then other spots are going to be prone to leak. So if you're finding that you're having to over tighten your mask, then it might be the wrong mask for you, or it might be the wrong size. And then ultimately, it's a bit cut off here, but I wrote titration PSG, so a titration sleep study. So if you are having difficulties getting used to CPAP, you tried a bunch of things, you say, I just can't do this, then usually what I like to do is I send someone to the sleep lab for a titration study. And the benefit of that is that the sleep techs are very, very good at doing this. And when you get there, they'll look at your own mask and they'll see, is that the right fit or not? There's a whole variety of masks in the sleep lab that you can try, and they fit you for several masks before you start the sleep study. Then while you're doing the sleep study, they'll turn up the pressure on that to try to treat the sleep apnea. And if issues arise along the way, they'll try a chin strap or they'll try you on a different mask, and they work with you during that study to try to get you on the right treatment. And actually that has been pretty successful in getting people who otherwise thought they could never use CPAP to try to use it. There's other things that go into whether or not a person can use a CPAP machine. So, CPAP, if you look at your CPAP machine, there's a whole bunch of different modes. So there's, auto CPAP. You can add, an EPR to it, so the pressure drops down when you're trying to expire. Some people are on BiPAP machines, so it drops the pressure even more so when you're breathing out, and then only increases it when you're breathing in for a little bit. Some people are on an ASV device, which has this very advanced algorithm that will kind of coordinate with your own breathing and that and stabilize your breathing. None of that stuff has really been shown to, improve CPAP adherence in all comers. What has been shown in a number of studies is different factors related to, the patient themselves. So ignoring the CPAP and just thinking about the person who's using it. So it's been found that people wear CPAP more if they have a higher health value. So if you think that, if you think, say, physical activity is important to you, or if you highly value your health, then you're more likely to wear a CPAP, okay? If you believe that you are someone who has control over your own health problems versus someone who thinks that your health problems are completely up to chance, then you are more likely to wear CPAP. And then if you feel that you are able to accomplish a complex health-related task, that's called self-efficacy, it generally means that you are more likely to wear CPAP. And these traits are all something that are modifiable, and if you have a positive experience with CPAP or a positive experience with the process of getting used to CPAP, then you're more likely to improve in any of these key factors and wear CPAP. Oftentimes when I see people in clinic, they're struggling with CPAP, and we hardly ever talk about the CPAP settings or that, because usually, the settings are pretty low or there's not a lot to change on there. But instead what we talk about is how they feel about CPAP, why they don't like it, and kind of their motivation for using CPAP. And if you can get someone talking about, why you want to use CPAP in the first place, and again, I don't do a lot of the talking, I just let the person do it. So if the person is telling me, why they are motivated to use CPAP, then we can help, we can explore that together and come up with a plan for using CPAP down the road. And oftentimes once people feel once they feel empowered and they have found their own motivation to use it, then they oftentimes will use it a bit more. It's a lot different than if someone just comes into my office and I wave my finger at them and say, wear CPAP because I said so. No one's going to do that. I very much recognize that this is something that requires the individual to go home and actually do it overnight. So I have a lot of respect for people who are able to, overcome these challenges and wear their CPAP overnight. I think it's pretty phenomenal. And they oftentimes, almost always, feel better when they come back in the clinic. So it's very rewarding to go through this with people. But some people, can't get used to CPAP, and that's okay. So, unfortunately, there's not very many other good qualities or good alternative therapies to CPAP that are used routinely. The accepted second line option to CPAP is an oral appliance. So oral appliances are also called mandibular advancement devices. So your mandible is your lower jaw. And essentially, the thought is that if you could pull your lower jaw forward, then you would move your tongue structure forward and you would open your airway. Generally, the bottom line for these devices is that they aren't as effective for treatment of the actual sleep apnea as CPAP. So they can't get that number from, say, 30 down to 4 in most people, but they can get it from, say, 30 to 15 or 12. But people tolerate them better and they wear them for a bit longer. Unfortunately, they're quite pricey, and there's no real trial period for using these because they have to be custom made. So there's no way to really predict that by going and purchasing one of these devices for $1,700, that actually using it is going to improve your sleep apnea or your symptoms to a significant degree. Some predictors of success would be a younger person who is not overweight or has a lower BMI, who has less tissue in the upper airway, so they think that the sleep apnea is more related to the tongue falling back in the airway. And then someone whose sleep apnea is more on the mild end of the spectrum and more positional dependent. So their sleep apnea is at least 2 times worse on their back than when they're on their side. Accepted contraindications are pretty minimal now. So if your body mass index is over 35, then usually it's probably not going to work for you because the tongue is maybe contributing to the sleep apnea, but it's probably a lot more related to weight. And then if you don't have enough teeth in your bottom jaw, then you're not going to be able to wear a device there. I also had a dentist decline to make one for a patient because they had poor oral health. So a dentist looks at all that sort of stuff before they make you one. So you can see here, it's just you put this device in and it pulls your jaw forward. That's what this cartoon is trying to show. And then you have more airway just in that area right behind the tongue. This is kind of good because it shows it's not, well, I guess it is kind of here, but it just pulls this forward to help open up the airway there. It has to be customized. So in this, in the trials that I've looked at customized devices, so it's made specifically for your mouth by a dentist trained in that, versus non-customized where you can just buy it online. The non-customized device essentially just hasn't really been shown to work. It really doesn't, improve the sleep apnea to a significant degree. So the customized would improve it by 14 versus 6 maybe with the non-customized device. Not really clinically significant. The non-customized device doesn't actually increase the oxygen levels, probably because it's not increasing the severity of the sleep apnea. And it's not really been found to improve your sleepiness. So ESS stands for the Epworth Sleepiness Score. So the non-customized device doesn't actually improve your sleepiness. So essentially you're wearing a dental appliance overnight, trying to treat sleep apnea, but it doesn't really do that. So I tell people it has to be customized, and I try to help them find a dentist if we can. In general, if you're comparing the first line option, CPAP, versus the second line option, the oral appliance, CPAP is more effective for treatment of the sleep study parameters. So if your number is your AHI, your choking episodes per hour, it's better at getting those down to 0. It's better at improving your oxygen levels. But in general, if you compare the two, they're oftentimes similar in improving, in the right population, in improving, sleepiness. In simulated driving, you're less likely to cross the lane, improves quality of life, and it can actually lower your blood pressure to about the same degree. They use this metric here. I've never actually seen this for anything other than comparison of CPAP and the oral appliance with the mandibular advancement device. But essentially what they're saying is that, it's called the mean disease alleviation. So if you are, wearing CPAP, which is very effective, 90% treatment effective, for only 56% of the time, then you've only alleviated the disease 50% of the time. However, if you wear your mandibular advancement device for, all the time, and it's only about 56% effective, it actually appears to be the same as wearing CPAP half the time. So that's one way to think about it. It used to be thought that you couldn't use one of these devices to treat people who have severe obstructive sleep apnea, but that's no longer the case. Although as that number gets higher, it's less likely that it's actually going to be effective. And you hate to see people, waste their money and time. So just two more things here. So positional therapy. So, people might not want to use an oral appliance or a CPAP device. So you can tell people to try to avoid sleeping on their back. And sometimes you can see on a sleep study that someone doesn't have sleep apnea at all when they're on their side, but they only have it when they're on their back. So you think, it would be great if this person could just sleep on their side their whole life. So usually I tell people if they're going to deliberately sleep on their side, that they should do something to make sure they sleep on their side. So this is known in the sleep world as the tennis ball technique, because I think the story is that it started with someone just sewing a pocket on the back of their shirt and putting a tennis ball in there. And you can see that if you were to roll onto your back with a tennis ball there, it would be uncomfortable. You'd immediately wake up and roll onto your side, or just roll onto your side subconsciously. There's been some studies that looked at this. You spend less amount of time on your back. Pretty surprised that people could spend about 9% of the time on their back with this there, but it reduces the severity of sleep apnea from, almost moderate to almost normal. And then the amount of time, so, the duration of that choking episode was shortened, and therefore the level of oxygen desaturation was also not as severe. And then the last thing we'll talk about is surgery. So, it seems kind of intuitive that, if you just have an obstruction there in the back of your throat, why don't you just surgically remove a lot of that soft tissue in the throat? And, I think that because, we talked about before, it's not just the structural component that is causing the obstructive sleep apnea, but it's a number of things. So I think this used to be performed quite a bit more often, and now has fallen a bit out of favor. This cartoon here is just showing what a tracheostomy is. So you can see here's where obstructive sleep apnea occurs up here. Here they just would, before 1980, if you had severe obstructive sleep apnea, they just cut a hole in your throat here and put this tube in, and then you breathe through this. So you don't have obstructive sleep apnea anymore because you're bypassing that completely. You do, however, have a tracheostomy. And then, of course, this is different types of bariatric surgery, which can be quite effective as well. We focus mostly here on this UPPP surgery. So you look here, you can see this is before they do the UPPP surgery. And here they remove the uvula. They've kind of removed some of this soft tissue in the back of the throat here. Usually they carve out, or they remove some tissue at the base of the tongue. So it only has, it has a very, it's essentially like flipping a coin, I guess. There's a 50% success rate. And for some reason, the success rate, I think because the trials were maybe a bit older, but the success rate in trials was reducing that number by 50% to an AHI of less than 20. So some people might still have clinically significant sleep apnea if their AHI is around 20 or even in the mild to moderate range. However, in some people, like if it does work, it might reduce the sleepiness that you're experiencing, but there's really no good predictor of success. It's kind of similar to the mandibular advancement device. I guess for all sleep apnea in general, if you want to see if CPAP works for you, you have to try CPAP. There's no way to predict that CPAP is going to work for you. for these UPPP surgeries, there, I've read some things where they try to put someone, to sleep and then do a laryngoscopy. So they put a camera in through your nose to look at the throat and see where it's collapsing and try to pick people based on that. But even that hasn't been shown to predict success in that surgery. If someone has really run out of options, this might be something that we talk about, but so far I haven't recommended this to anyone, although these surgeries still do happen. What's more common is a tonsillectomy. So in especially younger people, like kids and teenagers, obstructive sleep apnea is usually driven by tonsillar enlargement. That being said, though, as obesity rates in children increase, it's also being driven more by obesity. But if you have the right person and they have enlarged tonsils like this, removing them might cure their sleep apnea. So it's also, if I see a younger person and they have very severe sleep apnea, we're always looking in the backs of people's throats, but this is oftentimes when I'll refer more to an ear, nose, and throat surgeon is if they have this big tonsillar enlargement. I just want to shout out the SAIL program. So this is the, the treatment for sleep apnea can be quite expensive. So a CPAP machine can run, a couple $1,000 plus, the cost of the tubing and the mask. It's nice. Most people do have private coverage, so it's nice that the cost is reduced, hopefully to zero in most people. But in general, if there is a program where the government has, bulk purchased these CPAPs and, sell them, or I guess loan them to you at a reduced rate. It's usually a one-time enrollment fee, and then you're kind of enrolled in that program, and they help support you with any problems you're having with the machine and that. And it's very good. They're good machines. They're like the newest, ResMed machines, just like you get anywhere else. And it's a good resource to have. So usually you can qualify. You have to have a SaskHealth Health Card number, so you just run into problems if people are, say, from Flin Flon. You qualify automatically if you have moderate sleep apnea or worse, or if your number is above 5 and you're in what are called mission critical occupations, and that's things like long haul truck drivers, people who drive trains, healthcare workers, that sort of thing, where you need to be very, very alert at your job, or else people can be seriously harmed if there's an accident. So I know that's a long talk. I hope that everyone learned something. Sleep apnea is very, very common. So if you've been diagnosed, don't feel bad. It's you're not alone. You can do one of 2 sleep tests routinely to diagnose it. CPAP is the first line option. There's many reasons that someone has a difficult time using CPAP. But again, you also are not alone, and there's people who have been able to, overcome that to wear CPAP and have improvements in their sleep quality and quality of life. Yeah, so I'll take any questions.
Thank you so much, Dr. Ellis, for that wonderful presentation. Oh my goodness, you covered so much great information in a short period of time. And I definitely appreciate that you talked about all the different most common treatment options, but also how it really has to be individualized for everyone. And we really appreciate that. So we have a few minutes here for some questions. So we'll maybe get Joe to bring Dr. Ellis up on the screen here if we can. And we'll start going through some of the questions. And just remember that Dr. Ellis's presentation will be posted on our website in the coming days, lungsas.ca. So if you want to watch it again or send it to friends and family, you certainly can. All right, Dr. Ellis, well, we've got quite a few questions. We'll try and get to as many as we can. All right, so first up, people are wondering when would they, if they've been diagnosed or with sleep apnea, or they may have sleep apnea and they're not sure, when would they see a specialist, someone like you, as opposed to working with their GP?
Can you hear me okay?
Yes, I can hear you just fine. Thank you.
Yeah, that's a good question. You know, I think historically, all the sleep testing was controlled by the specialist, and it had to go through a hospital, and you'd have to stay overnight at the hospital and do that level 1 test. Nowadays, sleep testing is much more available, and your family doctor can order it through a number of avenues. So they can order it. Usually, how they do it is they go through a private CPAP vendor who will offer a home sleep apnea test. The other option is that sometimes some certain family doctors can refer to the sleep lab for a home sleep apnea test. And then the final option is just you can ask for a referral to you know, a sleep specialist. And anyone who practices respirology in the province has the ability to order a sleep apnea test at the sleep lab. And yeah, so I guess there's a number of different avenues. I guess the main takeaways is that if you do one of the home tests, say you think you have sleep apnea and you do the test and it doesn't come back showing sleep apnea, you could still have sleep apnea. So, you know, how our algorithm in the sleep lab works is if you have one of the home tests done and it doesn't show sleep apnea, we automatically order an in-lab sleep study so we can exclude it definitively. So that's the big takeaway point.
Wonderful. Thank you. Thank you. You answered that great. Okay. Another question here. We've got quite a few people that have seen promotions on TV and in social media. Can you comment at all on the upper airway nerve stimulation therapies that are starting to come or be advertised, if you will? Is this effective, something utilized in Saskatchewan or in Canada, or something you think that will be used in the future?
Yeah, that's a good question. And I thought this would come up because I've had people asking me in clinic and asking my colleagues in clinic, like if it feels like in the last 2 weeks, a lot of people have been asking about these devices. So I think they're doing a very good advertisement campaign right now. So basically, what the upper airway stimulation, it's called the one that's in market right now in the States is called Inspire. So you've probably seen some ads for that. And basically what they do is it's an implantable device. So it kind of is like a pacemaker. They implant part of it here, and then they implant another they implant 2 more sensors, and one of them goes underneath your chin, and it basically works by stimulating the nerve that your body already uses to protrude your tongue, so stick out your tongue. And it does that intermittently while you're sleeping overnight to move your tongue forward. The first trial for it, actually, like it's 2023 now, the first trial for it actually came out in 2014, and it showed that it benefited certain patients. And the current criteria for that device so as far as I'm aware, it's not approved in Canada yet by Health Canada, but it is FDA approved in the United States. So some patients are getting it done there. And the process that they used in the trial is the same as the process they're using to give it to people commercially or implant one of these commercially. And it's someone who has been diagnosed with anywhere between mild to a bit above severe sleep apnea. So their AHI or their number was 50 or less. And it has to, the maximum body mass index in those trials was 32. So they have a pretty hard cutoff of 32 for the BMI. And then the third thing and then it has to be someone who has tried CPAP, which I'll get into later. But so, and basically the next step before they decide if they can actually put it in is they put you to sleep and they do a scope into your upper airway, and they see how it collapses and where it collapses. So once you meet all those criteria, if your airway collapses the right way, then they'll say, when were you diagnosed with CPAP? Have you tried CPAP? How many times? Like they'll go through a whole rigorous approach to, you know, how you've tried CPAP and try to determine why you failed and if they can do anything to help get you on CPAP. And the reason for that is that even in their trial with the most carefully selected patients, a third of the patients didn't actually have a meaningful improvement in their sleep apnea, and some patients actually had worsening sleep apnea. The other criteria is that they have to have just obstructive sleep apnea. They can't have mixed apneas or central apneas to a significant degree. So yeah, I guess it's a long way of saying that they're not routinely put in Canada. They're put in specific centers in the United States, of which I don't know which ones do it. I haven't referred anyone for it yet. It seems promising in the properly selected patient, because when used in the right patient who can't use CPAP, it's the sleep apnea completely goes away. It doesn't seem like it's too, like there's some surgical discomfort when they put it in, it seems like, and then the way it stimulates the tongue, some people find that to be a bit uncomfortable. It is possible to remove the device down the road, but they try to avoid it if they don't have to, because they don't want to damage the nerve that sticks out the tongue. So it is a promising technology. It's kind of getting more mainstream in the United States, and yeah, it'd be nice to have any good options for treatment of sleep apnea in Canada for people who can't use CPAP. So hoping to see it a bit more down the road and get a better, diagnostic pathway and treatment pathway for that specific device.
Perfect. Well, that's great. And speaking of additional options, if people are struggling with their CPAP or they can't use it, would that be another reason why they may be referred to a specialist to help with some of those, where to find some of those other options and specific, perhaps oral devices?
Yeah, absolutely. Yeah,
Okay.
that if you're having trouble with CPAP and you haven't seen a specialist yet, then that's definitely a good reason to have a referral.
Okay. Okay. And then we have a few questions as well. If someone's on CPAP and they've been on it for a long time and they think they're feeling fine and doing well, when should and how often should they be monitored, checked? Should that be checked to make sure that everything's working as it should be?
Yeah, so the best reason to use CPAP is for symptomatic improvement. So usually what I tell people is that if I see someone in follow-up and they feel much better, then that's someone who I can say, okay, so you're feeling better, check. Let's see what the next step is, and then we can check your data on your CPAP download, or some people have access to AirView or some other cloud technology, so you can check how good the CPAP is working that way. And typically, what the research has shown is that if that number, that AHI number on your CPAP download is less than 10, then it's probably right. Like that, it's probably correct that way. If it's above 10, then it would be a good reason anyways to get the CPAP checked out, or see a specialist about having an in-lab titration, or seeing if you can do something about the settings. And then there are some people who have a residual number that's less than 10, but they still have a lot of symptoms. And then when we get them in the sleep lab, they'll have quite a bit of sleep apnea still at that pressure. So so I guess if you're doing well and your sleep apnea is well treated by your CPAP device, I'll see people in about a year and say that you can call me if you have any problems. But if you're struggling, then the studies do show that the longer you leave it go without addressing it, the less likely someone is going to be adherent to CPAP. So
Okay. Okay, well, thank you. Yeah, you covered a lot there. Thanks, Dr. Ellis. We have so many questions. We won't be able to get to all of them, but I'll try and ask maybe one or two more. There's some questions about, because many of our people viewing tonight are from Saskatchewan. They're talking about how Saskatchewan tends to be very dry and how they experience dryness in the throat and their mouth when using CPAP. And some people are also asking if dryness in the nose from maybe inflammation or allergies, can that affect the sleep apnea as well? And any tips that you have if they're experiencing some of these symptoms?
yeah, absolutely. So yeah, it is very dry in this province. I hear that. I guess it depends where the dryness is. If the dryness is primarily isolated to the nose, then that can be a bit more difficult. The first step would be to ensure that you're using a CPAP machine that has a humidifier. I think everything that is provided by the SAIL program now has a humidifier, but historically some did not. And anyone using like a travel CPAP, for example, doesn't usually have a humidifier with that either. So I would check your humidity setting or ask your doctor or your CPAP provider to check your humidity setting. Some people find that moistening the membranes of the nose with either a saline spray, like you can get a saline spray, or use like a rinse bottle just to moisten the nose before you go to sleep. Or sometimes you can get some sort of lubricating gels that you can put into your nasal cavity a little while before you sleep, and that can help with the dryness as well. That lubricating gel is oftentimes used by our patients who need to use supplemental oxygen 24 hours a day, and that's very effective at improving the dryness in their nose and prevent nosebleeds. And they can still use their oxygen despite that. So those are kind of the things for dryness in the nose. If it's dryness in the mouth, often, and you're using, if it's dryness in the mouth, that's oftentimes due to leak. And if you're wearing a nasal mask, that's oftentimes due to leaking out the mouth. But sometimes even people who have like a full face mask, if it's leaking, you can have a dry mouth. So paying very close attention to leak and trying to get, even though we have acceptable limits for how much leak is normal, if your leak is anywhere, above 10 and you're having these symptoms, then working to try to control that leak even more should help with the dry mouth. And then again, that's another place where you check the humidity setting on your CPAP.
Okay.
And always, like if you are struggling and you aren't getting your answers, and you aren't seeing a specialist yet, like you can go see a specialist, or you can to go see a specialist. I think that's an okay thing to do.
Awesome. Thanks, Dr. Ellis. Okay, I think we have time for maybe just one more question. We have a few people that are saying that they have sleep apnea. They are on a CPAP machine. But their bed partners have noticed that they're still pausing when they're sleeping in their breathing. Is that normal? Does that mean that their machine maybe isn't working properly? What would you advise for those individuals?
Yeah, that's a good question. It could be due to a number of things. Um, you know, one of There's another type of sleep apnea that we didn't talk about today. We just talked about obstructive sleep apnea. But sometimes once you treat the obstructive component of the sleep apnea, it can give way to something called central sleep apnea. And that is more or less regulation of the control of breathing. So you don't have any more choking, but the way your body regulates the breathing overnight will cause you to have episodes where you breathe a bit faster, and then you hold your breath for a little while, and then you breathe a bit slower. And those conditions like that, you can see that in people just with sleep apnea or obstructive sleep apnea who get it treated. But it's also common in people who have conditions like atrial fibrillation. If you've ever had any sort of problem with your heart, like a low ejection fraction, or we call it heart failure with preserved ejection fraction, just like a stiff heart. And then people who take long-acting pain medications, so things like slow-release Dilaudid, slow-release morphine, methadone, those sorts of things can predispose you to that. So if you are worried about something like that, sometimes it doesn't show up on your CPAP download. And if you are worried about that, you can just ask to see a sleep specialist, and we can talk about it and see if you need a sleep study to go look at that even further.
Okay, wonderful. Well, thank you, Dr. Ellis. I'm just so grateful that you took the time to share so much of your knowledge and experience with us. We really appreciated you kicking off our Lung Life webinar series. And thank you to everyone that joined tonight. We hope you learned something. I know I sure did. Again, if you want to watch this again in the coming days, it will be on our website, lungsas.ca. You can also share it with friends and family. And I also want to invite everyone to join us for the other presentations that we have in our Lung Life webinar series this year. They're all on our website, lungsas.ca. And a big thank you to our sponsor, GSK. Without them, this wouldn't have happened tonight. So thank you so much. And thank you, Dr. Ellis. I hope everyone has a wonderful evening and a wonderful sleep as well. Thank you. Good
Thank
night.
you.